very much, Maurice Tombeni, the leadership at GIBS, and all the distinguished guests who are here. The way you introduced me, thank you very much. It felt like I must stand up and say, Amandla. But briefly, just to say, if I can just take on from where you left, indeed, South Africa is going through a lot of challenges with very high levels of poverty, unemployment, inequality, and the challenge of really, for the past 10 years, being trapped in a low growth trajectory, which is really making situation a little bit more difficult. Because when we started off in 1994, we utilized the good growth to be able to have adequate resources to deliver the services that was already trying to create, to bridge the gap between those who have been completely disadvantaged, poor, marginalized, and the rest of South Africa. So it remains a very serious area of unfinished business to solve the problem of inequality. Now, if you want to know what inequality means, the quickest example is you go to Sandton, and we always pride ourselves as being the most, the wealthiest of the estates in the continent. And then a kilometer away, you've got Alexandra, that's been marching frequently now to Sandton to say, look at the squalor, look at the poverty, look at the unemployment, look at the shacks, look at the sewage, look at all of these issues. And this is actually the story of South Africa. The level of inequality actually poses the threat to future economic and political stability in the country. It's got to be addressed. We can talk about all sorts of issues, but today we have to deal with the inequality on the health side. What do we want to see in a health system? Firstly, we'd like to have a health system that will have the outcomes of giving you the best health indicators. Long lifespan, low mortality, mothers don't die when giving birth, children grow and get delivered and grow without having a problem, even if the mothers have come from a poor background, and that we can control preventable diseases, tuberculosis, HIV, polio, measles, etc., so that those diseases don't cause massive deaths in the communities. On the other side, we have now got a whole new area of other diseases which we call non-communicable diseases, heart diseases, cardiovascular diseases, diabetes, cancers. That whole package of diseases is rising as a second kind of epidemic in the country. Unfortunately for us, we've got two types of epidemic growing at the same time. What is the ideal health system should be able to do? It must be able to help us to have a system that controls both and therefore invests in the wellness of the population in such a way that each individual is the first line in the creation of good health. And that the next line is support from the government, state, and all the various departments in ensuring good health. So, for example, problems of diseases, children dying of diseases, the government should be able to give you good sanitation, good water, clean water. Then, of course, the people there don't have to suffer from serious diseases that could have been prevented by simple socio-economic development programs around them. But this is what we're looking for. When we come to the health system, what would we like to see? Well-trained staff, adequately staffed hospitals, no queues or short queues, security of supply of medication, and easy access to facilities, availability of health information, early prevention of diseases, early screening of diseases, and early interventions on diseases so that they don't complicate. And then you must then have a system that will allow you to go inside the system without a restriction based on whether you are employed, poor, rich, or have a medical aid, or you don't have. The system must allow you to go in and be treated in the context of what the nature of the disease that you're suffering from. It must therefore take you through the system. So the one who needs a heart transplant must go through the system and not be stopped by the fact that they can't afford to be able to perform such an operation. There's a kind of system that we're looking at. Now, has anybody got enough money for that? No. So what do we have? We've got those who've got enough money, and we've got those who don't have money. We've got the state in between, and the issue is the proposal that we're working on is based on the UN, WHO, and a number of OECD countries who are working on what we've got already. They've achieved what is called universal health coverage. In those instances, universal health coverage basically means that you must actually open up the health services to be able to allow people into the system. And so when we make our proposal for the national health insurance, it becomes an insurance because of the basis on which it operates, social solidarity. We all put in the resources, but then those who are the sickest will then be needing it more than those who are healthier. Those who have got, those who are older, like myself, will then need it more than those who are younger, like yourselves. And so the issue at the end of it is the issue of social solidarity. The trick is being able to create this fund that should be well managed and that must be able to procure the services, the health services, on behalf of all the people. And that is a model that we are talking about. We've actually taken it from benchmarking with a number of countries. And at the moment, the WHO, the whole continent, and the whole, literally on all the continents now, they are actually moving, pushing everyone to say, let's make sure that there's universal health coverage. The World Health Assembly has now put this up as the #1 issue in the fulfillment of the Sustainable Development Goals. One of them is ensuring the access. So the President is going to be going next month to account how far we are as South Africa on this matter. So we have therefore brought in the issue of the national health insurance as the way to achieve universal health coverage. We believe that's a system that will work in South Africa. Every country has got its kind of version of this national health insurance, but at the end of the day, one of the issues that we have actually been discussing with many of the countries, like about 2.5 months ago in Japan, they said to us, when we started the national health insurance in Japan 50 years ago, we were actually poorer than you are in South Africa. So don't think there'll be ever a time when the economy will be so good that it's the right time to start. You start now, because when you look at national health insurance, it is more about an investment in health, and it's an investment that must not be considered as wasteful expenditure. It must be an investment that must be considered as investment into human capital development, healthier population, economic growth. It's out of that kind of investment that you are also going to begin to build on the prosperity of the country. That is the approach that we're taking. We have now tabled a bill called National Health Insurance Bill. As the bill goes into Parliament, largely it deals with the structures, really, of what the structures of the bill will be. So, for example, it talks about the executive that will run it. It is an entity which we call Schedule 3 entity. These entities are under the PFMA. They are like an entity. You've got two types of entities there. You've got the Schedule 2, which is like the big ESCOMs, the SAAs, et cetera, the ones that you read about. Then you've got the others, such as the NHI is along the lines of Medical Research Council, HSRC, et cetera. And the mandates are not quite the same. These entities are entities which are focused on basically receiving all their revenue from the fiscus, and in the process, the fiscus, the mandate is for them to spend on the designated services. And so the structures there, they talk about, benefits advisory committee that would look at what kind of packages of services that are going to be purchased through NHI, On the other side, it talks about health benefits prices, pricing advisory committee, and that again is about negotiating the issue of prices. So all of these are some of the structures in there. And then in the process, of course, there are a few other issues which I think are specific preferences that have been put into the bill. Amongst those is the issue of a single purchaser, wherein to ensure the maintenance of a system that avoids distortion and inequality within it, and you will have what we call a single purchaser and single payer system. Then the question arises on a number of issues. Firstly, the role of the medical aids. Okay, let me start by saying, in general terms, how do you get to finance all of these, this kind of thing? Because this NHI is a fund. How do you then generally fund it? The approach is that to the fiscus, whatever we have from health budget right now goes into that. But in the process, therefore, we're looking at the sources. Could be around the area of taxation. It could be around the area of surcharges, contributions by employer, employees, and so on. But we take it as a mandatory contribution, which basically creates a fund for the nation. And then everything else that, like the medical aids were, that the medical aids would be working on would be something that the system doesn't reimburse, and therefore that gives you additional cover for those who are looking at that. This is how the system is working in most of the countries that we've been benchmarking with, and that's the approach. Now, the question is, when are we going to get this NHI? We're starting the processes of instituting NHI. But the way we want to go about it is to first correct some of the issues that we're talking about. So we have to deal with the issues of staffing, and we've committed to push up the numbers of staff so that the establishment in health is sorted. The issue of the morale of the staff, the levels of competence, the supervision, and so on comes into that. The issue of the security of supply of medication, that also we have to say that they must protect the budget so that you don't have a story of a province that says we have run out of money for medicine. It shouldn't have run out. It must have been kept and protected. The issue of infrastructure, we believe that this infrastructure that we've got, through creative and innovative ways, we can actually revamp it within a much shorter time horizon of up to about 5 to 7 years. And here we are looking at various combinations of private sector and financing and creative financing, because looking into the system, we realize that it is possible to have rescheduled repayment of debt over a period that can cover investment which you can do now. I'm talking here about the examples. Some of you would have known some of the examples that we've been through. I will just give you an example of Nkosi Albert Lutuli. We went for 15 years on a PPP arrangement. It still remains one of the best facilities around. So I was saying that it's possible to do those kinds of things, and in the process, we have to then deal with the issues of proper delegations and so on. And one of the things that puts everybody off is the issue of maladministration and incompetence, as well as corruption. And these are the issues that we must be upfront here to say that we accept that these are some of the problems. And the fact that there's been so much of it with the state capture, with whatever commissions out there, these are lessons that we have to learn. And if there's anything that we want to know, want to say we have learned out of this, is that South Africans, not one will actually keep quiet if they think there's corruption. We have to really go on a concerted effort to deal with it. So we want to be creating a structure that's going to reinforce the oversight over that NHI fund that will have all the special investigation units overseeing it and so on, and using technology so that you can actually interrupt and intervene when there's any form of corruption taking place. And that will get people who are specifically trained, competent, and well qualified to be able to run NHI kind of facility. So we're taking a number of managers out into different countries. We've got agreements with a number of countries that have been wanting to give us support when it comes to the issue of the NHI, UK, Japan, France, and so on. They're all ready to give us support. So we want to send people out there. So a number of them, about maybe 30 or so of them, will be out. There's the first batch, they'll go out, Then, of course, the deans, the heads of academic institutions, have come on board to say they want to bring their own academics to the same countries, and therefore partner and twin with those institutions so that they can bring and domesticate the capacity to manage NHI. So that is one of the things that we're going to be doing at that kind of level. So that is what we're looking at. So we're going to go into right now, as soon as we get the bill passed, or maybe even before we pass the bill, we're already looking at the structure of how we implement NHI. And in the process, there's going to be a policy side of the health department, then there's the NHI side of the thing. It works like that. So the one side, therefore, deals with the purchasing and the servicing and delivering health services. In that process, we therefore need to be creating the structures that will manage this kind of fund. Pretty complex in the way that it will be operating. You would have seen how the private healthcare funding is operated. So you've got all sorts of expertise that is needed there. That's the kind of expertise we're going to be needing here. And in terms of building this whole thing, so we have to correct the things that are wrong in the public health service. On the other side, we've also got to be putting up the structures that are needed for the NHI. Build it up in a phased manner, and between now and the next 5 or so years, we believe that we're going to be actually making a difference in the way the services are run. At the end, of it, we will then be looking at what packages are offered on NHI, and then start the negotiations with the medical aid fraternity in terms of what then becomes the services that the packages that they will offer, and balance the issue up at that kind of level. So there are numbers of issues. I've avoided talking about some of the distortions that are going on in the health system that make our system a lot more unsustainable. For example, the biggest issue of making our system unsustainable is the issue of underfunding on the health side, public sector. That underfunding is serious. It needs to be corrected somehow, either directly from the fiscus, or we actually find creative ways of being able to get investment into that sector, like I'm talking about the infrastructure. So that's one of the issues. Sorting out the issues of corruption, as I've said, staffing and medicine, et cetera, et cetera. We're working on all of that. There are very interesting innovations that we are, for example, seeing about the use of technology, which I work quite a bit on this in this case. So there's already products where you've got what we call e-pharmacy, e-dispensing, that makes it much easier to actually reach out to a number of people who are away from the hospitals, and therefore get people to get treatment without having to go into the hospital. So there are a number of those systems that we're actually working on. Some work has already been done, including delivering chronic medication using drones and those kinds of things. So the issue being, how do we reduce the queue as we go in here? When we talk about NHI, there will be what is called contracting units for primary healthcare. The entire system, its philosophy has to be based on primary healthcare. So first issue is to go out there and make sure that we pump a lot of information on ensuring community wellness programs, so people must know what it is you need to do: exercising, good nutrition, early screening of diseases, go and visit your doctors and be seen and treat things early, et cetera, interventions early, as it were. Vaccinations, prevention of diseases, also dealing with palliative care, rehabilitation out there at the community level. So your cadres, community health workers, have to be a very strong component. Nurses and clinic nurses and clinics going to be a strong component. General practitioners in the private have also to be brought in, and therefore they're going to have to be part of this network. Over the next few years, we'll be working on the modalities of how we're contracting on those. And then your district hospital doctors doing outreach, going out there in the communities and managing this whole system, so that at the primary healthcare level, you have got a strong program that creates very strong health promotion and wellness at that level. And then, of course, once you need to get admissions, I mean, that whole system will triage people as they move up. You will be able to make a choice that this is my general practitioner, etc. It's no problem. And the system, we want to actually, right now, create what we call we've got what we call a patient register system that has actually gone to check. We've got about 40 million people already recorded on the system to know who's been using our system. Working with Home Affairs, we want to be able to tie up the system such that you can walk into Pelonomi and say, I am from Mthatha, I'm not well, and therefore when you are there, then the system must be able to discover that you are a South African, you are entitled to this. And who else will be entitled? Not only South Africans, but those who are in South Africa with residence permits and asylum, etc., who are recorded officially within Home Affairs. What we can do then, what we have is an obligation on emergency services for someone that might be undocumented. Who are you? We don't have an ID, we don't know who you are, but then you are sick, and therefore we must treat you and deal with you in terms of the emergency treatment. So that's basically how the whole system has to run. Then there's a lot of other controversies. And I believe many of you are here for that one. One, someone is accusing us of running an unconstitutional bill. Now, guys, that's politics. I can just tell you this. I had the good fortune of having been part of the first team that went to establish the health department. There was no law. We sat together, discussed the approach, we decided how the functions must be run, and once we'd agreed on the approach, then we went to do a law that basically recorded the way we thought that the various spheres of government must operate. So at any one time, if you have to change the system, you start by talking, and then once you have discussed and you fix the rules, then you'll be able to do that. The Constitution says there's concurrence of powers on health between the provinces as national and national. Now, in the case of this bill, we're actually building that issue into a cooperative model of what we call cooperative governance between national and provincial. The heads of departments and MECs, what we call National Health Council, are seized with that to look at what is their role. So when we say concurrent, concurrency means you either will have a national legislation that will define the role of the provincial health department, or you will have a provincial legislation that will define the role of the public, provincial health. You can have a national national legislation that will delegate certain powers to the provinces. Still, that's still concurrent because you are playing a role at that level. So that side is us when we're sparring at political level. It's unconstitutional, it's not, and so on. I'll put that one aside. The next issue is the NHI will bankrupt South Africa. Well, we're here back to differ. And the point I made about Japan, who were saying to us, we today have got the longest life expectancy. We started this thing a few years after the war. Japan was ruined. You can never be wealthy enough to start. You must start and then build up your system. Now, what NHI is on day one and what NHI is on year 25 is not the same thing. You build on it, and in our case, we want to deal with it and build it on the basis of what the country can afford, and therefore what we can actually collectively agree to say these are the priority areas and build on it. By the time I leave the service, whatever that will be, it will not be the same as what it will be when your grandchildren are actually part of the service. And therefore, it's going to be something that's going to be evolving as we will be growing into it as we move on. So that's the issue. So we disagree about the issue of bankrupting the system. Then someone mentioned here something about loss of share prices. I don't have qualification to talk about that. I can just say to you that it's not usual that with something that there's no law, because when we start talking about how you are going to pay for the bill, there's going to be a money bill that the Minister of Finance will table to say we're going to tax you, we're going to give you tax breaks, we're going to do this and so on. So there's no such. It's not going to be there for another maybe 5 or so years. Now, to actually have share prices crashing today on something that is anticipated to happen some other time, it's not usual. However, there have been a number of other things that have been, in some case, it looks like there's really been very negative sentiment that's created a bit of uncertainty in the market, And it's not really because of the NHI, but it's because of some of the comments people have been making on the one side. But on the other side, and of course what we believe is important, is South Africans to get into a conversation so that there's a real concern. When you start something new, everyone gets a bit uncomfortable. Hey, what is this going to cause? What is it going to mean to me? And so on and so on. So we need to be able to get to that level of the conversation. But there were other issues that in one of the big companies, I won't mention the names, there's a big, some economists were out there saying, no. It's not just about health. There's a whole lot of other components here that we are not happy with the calculations and so on. I can give you a reference to that if you want. But the point is that I think there's a bit more there than what we could only just attribute to the NHI. Then others were imaginative enough to say that, no, actually, you are going to have a nationalization of all private sector facilities. Now again, there it's a weird kind of politicking, if I may say. If you've got a general practice, private practice, government can't take that over. No one has got an interest in doing so. You've got a private hospital, the government can't take that over. You've got a private chemist or dispensary, government can't take those things over. Rather, when we talk about contracting the services, we're going to have what we call Office of Health Standard and Compliance. That must force government health services to reach a particular standard and be accredited. Then that standard must be the same for private and public sector. And in the two, then you get, once you're accredited, then you can actually contract with the NHI. So that's how we're hoping that the system will work. And therefore, there is no way we're going to be taking over anybody's facility, as it were. No nationalization. I think we've had a long enough talk for now. Can I just say thank you?
Thank you. Will you